All right, Dr. Sarah Boyles. This is an episode that's been in the making for a while. We both kind of had to work around our schedules, but this is going to be a good one because I find in passing, whether it be friends or clients, often have questions around surgical options for bladder leaks. And I think how it often comes out is something along the lines of, what's that thing they do to lift your bladder? Or what are those things they put in, something like a tape or something? So I think this will be a great episode that I can share with not only clients, but I think providers will learn a lot from this too. And I just want to say really quickly before I ask you to introduce yourself, Sarah, I really admire what you do. You have a podcast called While You Wait, and I've listened to a few episodes, and I was specifically interested in the first episode that talked about your why, because I'm always interested. I'm like, I know this woman's going to be very busy. I wonder, like what's at the heart of her reason for doing this. And I think it's all in the title. It explained to me so much. There's a group of us here in our community that have been trying to do something similar. Like the healthcare wait times are enormous, and people don't often have to go see a specialist first, or they go and they can't maximize their short amount of time when they go. And so I've been so impressed that you've been able to not only probably step outside your comfort zone in releasing that, but also just spend the time. And I think it's hard taking that extra time, but it sounds like you're really dedicated to your practice and helping your patients down in Oregon. I know you're based in Oregon. You're a urogynecologist. And other than that, I want you to tell people a little bit more about yourself before we start talking about bladder slings.
Yeah. So, like you said, my name is Sarah Boyles. I'm a urogynecologist. I've been in clinical practice for about 18 years. And so, that means that I only take care of women. I only take care of women who have pelvic floor issues. And sometimes I think that's surprising for women to hear. A lot of people haven't heard of urogynecologists. Um, and I think some people are surprised that there is enough work to keep us busy. But I would tell you that there is an awful lot out there. Women don't like to talk about these issues, but that doesn't mean that they're not really prevalent. And I am very busy clinically. I say the same things over and over again. And so my podcast was a way to get some of that information out there to more people. I mean, I would like to say these things. I don't mind saying them over and over, but I would like to reach more people. And it all got started because some friends of mine who are local, who send me a lot of patients, and our primary care physician said, waiting to get in to see you, it's just taking so long. And what can people do? What can we do to get women started? And so that's kind of how it all got started. And you're right. It's very um, it's almost an addiction in some ways, right? Because when I post an episode and then someone comes in to see me and says something like, that episode was really so
Mhm.
very helpful and I did these things, or they come see me and they say, oh, I listened to that episode about how to optimize your first visit. And so I did all of those things and I'm ready. And this is what's bothering me. And I journaled my symptoms and I can tell you everything you need. All of that is very gratifying to me.
Oh, absolutely. I feel I can 100% agree with that. It's one of the reasons I set it up too. And I think, again, most people have to pay out of pocket to see someone like myself, and there's barriers to that. And I always
Huge.
think so much of what we do is education, right? And so when there's a certain amount of time, I found the same thing. I'm repeating that same spiel over and over again when this doesn't have to happen one on one. I want to be able to individualize my message to you or my assessment for you instead of spending that whole time telling something you could have listened to before. So, yeah, I
Yeah,
agree.
I agree with that.
Yeah, it is kind of like it's a time, but I think it helps deliver better care in the end, right? And I think
I think yeah,
yeah.
I agree with that. And it's just been really rewarding for me. Although, it is strange when someone comes in to see me and it's the first time we've met, but they feel like they've known me, right? Because
Yeah.
they've listened to some of the episodes. Sometimes that's a little disconcerting. Um, but I also think it's really helpful in that clinical relationship, right? Because we're starting just a little bit further down
Mhm.
the road.
Rapport is one of the biggest things, isn't it?
Yeah,
And so for them to feel
absolutely.
like they So, let's talk a little bit about I've had an episode before where we've talked about stress incontinence and some of the options, but didn't go into detail around, what happens when you do a surgery for incontinence. And I thought let's back way up because I want people to have a bit of a big picture here when they're thinking about it. And so let's start first with we're going to talk today about surgery for stress incontinence, but let's start a little bit. Will you explain to listeners first, Sarah, like what are the different types of incontinence for so
Yeah.
people can figure that out first?
Yeah. So in women, there are four types of incontinence. There's stress incontinence, and stress incontinence is when you leak with coughing, sneezing, exercise, right? So there's a pressure in your abdomen that pushes out a little bit of urine. Urgency urinary incontinence, and that is when you're going to the bathroom all the time. You feel a strong urge to get there. You're worried about making it. And sometimes you might leak before you get there. Mixed urinary incontinence, which is both stress and urgency. And then overflow incontinence, which is when you're not emptying well. And so, because you're not emptying well and you're always full, a little bit just kind of leaks out um, over time. Incontinence happens at all ages. I think a lot of people assume that it only happens to older women, but about 10% of women will leak their entire lives, including, as children and as teens. Stress incontinence tends to become more common after delivery and pregnancy. And then urgency incontinence becomes more common as you age.
Mhm. I actually just finished doing an online appointment with an athlete in her 20s, a track athlete that has incontinence. And so,
Yeah.
like stress incontinence. But exactly, I think it's always been thought before as a problem with old age or, related to birth, but
Yeah.
not at all. And I think it's
No.
important that you point out those differences because we're going to be talking today about the options for stress incontinence, and they're quite different, right? When depending
Mhm.
on what type of incontinence you have, it's kind of, I always say the same for like knee pain. Like, not all knee pain would be treated the same. It depends if you have a joint issue, a meniscal issue, a muscle tear. Like, they're not all the same. So they wouldn't all get the same surgery. And so we're going to be talking a little bit more specifically about the stress incontinence now. But wouldn't you say, Sarah, there's been a lot of change over time? Like before, I think people used to like surgery was their primary option. So I think that's where there's still a lot of messaging out there that if you have incontinence, you either have to live with it or have a surgical repair. I think that some of that messaging is still floating out there. But as we talked about before we hit record, we're always learning in healthcare, and there's so many different options now to manage stress incontinence. And what I find this is typical course of events in healthcare, and what I normally see is someone, maybe well, I think people are hearing now more from podcast episodes or social media or something that if they have stress incontinence, that there's options, and sometimes they explore those on their own. But often still what happens is, maybe they feel comfortable telling their family doctor that they're having stress incontinence. Quite often that family doctor sends straight to someone like yourself, like you mentioned, straight to a urologist or a gynecologist, and then come a lot of the wait times. But I'm curious to know, like, what else are you seeing with trends, like people that experience incontinence, what's next for them? Does that make sense? Like, what are you finding? People maybe less people come, straight to you and they try other things first and then show up to you, or would you say, just as many people come to you first and you're recommending some of the other conservative options? Talk a little bit about that.
Yeah, I think so. I think it's actually the opposite in the United States right now. So, it used to be that I would see patients who had been evaluated by their primary care physician, maybe started on some medications, maybe sent to physical therapy, right? Had done some things. But right now we have such a shortage of primary care doctors, and I want to be clear that I am in no way complaining about primary care because I think it must be the most difficult job on the planet.
Hmm.
But they're very quick to refer out, right? Because they're just so busy with so many
Mhm.
things. And so, I see a lot of patients now who have leaking, but who haven't tried anything, right? And so, sometimes that makes people leery to come see me because I am a surgeon, right? But, probably about 50% of what I do is non-surgical. But just because you come see me doesn't mean you're signing up for a surgery, right? I can talk to you about all of those options and, all of the things that might be contributing to your incontinence. Some of the things, there are a lot of lifestyle factors that can make stress incontinence worse. There's definitely a hormonal component, right? So sometimes younger women will come in and they'll say, I leak so much more at different times in my cycle, and that can absolutely be true. Women who are perimenopausal and menopausal and have less estrogen will absolutely have more stress incontinence. And then, we see a lot of patients who have gained some weight, and that additional weight gain will definitely make stress incontinence worse too. And so, those are always really important things to talk about because somebody might choose to modify those factors right before they do something much more aggressive, right?
Mhm.
And I think in talking to women, it all depends on how much leaking bothers you and when you leak, right? A lot of times I'll see athletes who, only leak during one specific activity. And then if we can do something like try a pessary, which is a vaginal insert that can stop leaking, that might be a great solution because that athlete, while they don't like leaking, I mean, they definitely don't want to take any time to recover from a surgery.
Mhm. Absolutely. And I'm sure you kind of touched on that, like how much does it bother them? I see, and I'm sure you see a kind of a wide range there of people that like sometimes people will have a lot of leakage and but when you ask them, they're like, actually I can live with this. But other people will have felt one drop and they can't live with that, right? And so I'm sure you see a very wide range in how it affects people's quality of life.
Yes, I definitely agree with that. I mean, some people are bothered by very small amounts of leakage and other women are much more tolerant. But I think it's also um, you have to be so careful in your questioning, right? Because if you say, does it bother you? A lot of people will say no. But then if you ask about giving up activities,
Mhm.
if you ask about body image issues, if you ask about intimacy, right? There are little ways that incontinence starts impacting you that you might not really be thinking about, right?
Absolutely.
So, yeah.
I actually saw a statistic the other day that this is a Canadian statistic, but the direct cost of managing incontinence is 5 point something billion dollars a year in Canada. So like $6,200 per individual. And that's, if you're looking at things like pad cost, hospital admissions and hospital fees
Yeah.
and nursing home fees, like just the economic impact.
It's huge, right? And so it's interesting to think about. But I say the same things to patients over and over again. And one of the things that I say frequently, and I truly believe this, I think it's hard to age gracefully when you have incontinence, right? Because
Mhm.
over time you give up activities, you stop being active, you stop being as social, right? And in order to age gracefully, those are all things that we need, right? You have to do those things. I mean, there are lots and lots of studies that show that, with activity, with good social interactions, you will age better. And so I think it's really important for us to think about that in terms of prevention.
Mhm. And so, will you explain to people? I mean, you've touched on a little bit like childbirth, aging, hormonal changes. Will you get down to a little bit more detail here, Sarah? As in, like, when someone comes into you with stress incontinence. Well, and maybe I'll start with kind of like what I would be thinking. So as a physio, it's still first some of the things I'd be thinking and then what you'd be thinking. But when they come in, I'm obviously thinking of what's their age? Yeah, like what's going when did it start? What kinds of things do they do? Um, I also know just too that I'm going to be thinking of the pelvic floor because I think of it like a valve. And I think, okay, there's urine coming out. So obviously the fill pressure is higher than the closure pressure of the valve. So, what might be going on there? And this is something I talked to this previous athlete about is just there's a lot of tension. So I'm thinking, why is there tension? What's the stress like in her life? How does she recruit her abdominals? How does she breathe? Things like that that would make me wonder how much pressure's on the urethral, like the pelvic floor. But then also too, certain things like urethral hypermobility. I know that movement of the urethra can in like the quality of the tissue and the movement of the urethra is something that sometimes, a urologist or someone like a urogynecologist has told me more about, or they're describing that this person has. But certain things are in my wheelhouse, basically, or in my toolbox to help, and you'll be thinking of different things. Will you talk a little bit more about some of the factors that are in your head? Oh, this person's having stress incontinence. What things are you wanting to rule out or rule in?
Um, so anytime someone comes into the office and they have stress incontinence, actually any form of incontinence. So I do ask a lot of the questions that you just mentioned, right? Because one of the questions that I always have is PT, yes or no, right?
Mhm.
And for most patients, PT is at least part of the solution, maybe not the whole solution, but it should be part of the solution. But some of the additional things that I'm always thinking about, do you have neurologic symptoms, right? Could there be something else going on? We don't see it as much with stress incontinence, but especially with urgency incontinence, sometimes there can be different neurologic diseases like multiple sclerosis. That's not the most common thing, but that's definitely something that I'm thinking about. I think about pregnancy and future childbearing, right? Do you want more kids? Are you done having kids? Um, the general recommendations are to not do a surgery until you're done having your kids. There are definitely exceptions for some people, depending on how just difficult their leakage is. But in general, we don't do slings if you want more children. Um, Looking to make sure that it really is incontinence, right? So I've seen patients over the years who have infections or who have a discharge. I've seen patients who have a cancer, and maybe that cancer creates a discharge that you think is incontinence. That can definitely happen with fallopian tube cancers or uterine cancers. Um, Sometimes, if you have a big uterus and that, your big uterus is sitting on your bladder because the uterus is right behind the bladder, it's almost like you're pregnant. You'll get a mass effect because of that, right? So I'm looking at the uterus and what that uterine size is like. And then, the other thing is making sure that somebody empties okay. So, most women can tell if they're emptying all right, but if you've had some form of a nerve injury and you're not emptying well because of it, you may also not have sensation and you may not be able to tell. So that's always an important thing for us to kind of double check.
Mhm.
And I would tell you that, I probably diagnose somewhere between 1 to 3 cancers a year for people who come in with, just incontinence symptoms.
Hmm.
So.
What would your just so someone that's listening has an idea of what would they expect? Like what kinds of investigations or exam, like what would their exam look like?
Yeah. So when you come into the office, I mean, we do a full physical, right? I always look at your abdomen. I always look at previous incisions. We do a pelvic exam. And I would tell you that, most women associate pelvic exams with the speculum exam. I don't really care so much about the speculum. I don't need to see your cervix. I care about how your pelvic floor nerves and muscles work, right? Do you have normal nerve reflexes? Can you contract those muscles? Can those muscles stay contracted? Are those muscles tight and painful? What does your uterus feel like? What does the urethra look like? Do you have any cysts or masses around the urethra? That's the other thing. Sometimes you can have something like a diverticulum. So a diverticulum is a little pocket that connects to the urethra, and that can cause some leaking. Does the urethra move in you, right? Is it hypermobile? How big the opening to the vagina is? All of those things can,
Mhm.
lead to more symptoms.
Mhm. And so then let's say that they've decided that,
But I
go
should
ahead.
also tell you that, if somebody comes in, so everything about this has changed over COVID. And I'll frequently do virtual visits with people before they come into the office. And I think virtual visits are really nice for, the first interface with a urogynecologist because you don't even have to worry about the exam. And a
Mhm.
lot of people are so worried about the exam that just kind of talking ahead of time is nice and reassuring for them. And then we can talk about what that exam is going to look like when they come to the office. It also is totally reasonable. It takes more time, but sometimes people come in and say, I just want to talk today,
Mhm.
right? I'm not interested in a whole exam. And that too is okay. I mean, you have to understand that I have more limited data about you if I don't examine you, but we can talk about, different treatments and different things, and that's perfectly fine.
It's like such a great point because I'm the same with my practice. Like quite often I encourage virtual appointments first
Yeah,
just so that you don't I don't want you to feel nervous. I want you to feel like your needs are met and your questions are answered and you have a little bit more understanding of your symptoms and your options before I look because but other people you probably find too, they don't feel like you understand unless you look. And that's everybody's so different that way as far as where they want to start. But yeah,
yeah.
I think that's a great
I
point.
just, I also feel like I learn a lot when I see people in their home environment, right?
Yeah,
I mean, you can just kind of see what might be stressing them out, right? I mean, it gives you a glimpse into people that you don't have when they come into the office.
absolutely. So let's say for the sake of this discussion that they have stress incontinence that is bothersome for them and that maybe they just needed to hear that they don't need to live with those symptoms and they wanted to know their options and you've mentioned that again, depending on what you find in your exam, maybe it would be some estrogen that you start them on. Maybe you'd recommend physio if they haven't tried it yet. Sorry, I'm in Canada, so we call ourselves physiotherapists instead of physical therapists, but same thing. So
I know.
maybe,
I like
yeah.
physio better though.
But maybe maybe they haven't gone there yet. They've come to you before they've seen a physio, so maybe you talk to them about that. Maybe you recommend a pessary. And I'm curious to know what you tend do you start with something like in recommending Uresta or like something that or like a poison pressa, or do you fit them with pessaries? Like what's you
My
know
go-to.
your go-to?
Yeah. So when I have someone come in and they talk to me about stress incontinence, I always talk about the big things, estrogen, weight loss. I think with estrogen, especially if someone comes in and they're within 2 years of menopause, I mean that I can really track when their estrogen started declining. If that parallels when their incontinence started getting worse, that always makes a lot of sense to me to start that at that point in time. But I always talk about it in the same order, and I always talk about it from conservative
Mhm.
to most aggressive, right? So I think everybody should try physical therapy first. I think physical therapy cures stress incontinence in about 60% of women. And so I think it's always a reasonable thing to start with. But I would also tell you that I don't force my patients to do PT. Some people will say, oh gosh, you
Mhm.
have to do it. Some women just don't
Don't
like
want
the
to.
idea,
Yeah.
they're not comfortable, it's too expensive. I mean, there are lots
Mhm.
of other
Mhm.
reasons. Um, if someone can contract their own pelvic floor, right, and they have good awareness, then I think they can do the exercises on their own. And so then I might recommend, an online program or, Kegel weights or Perry
Mhm.
trainer. But that person has to be able to they have to be pretty motivated, right? Because that's a hard thing for most of us to do. I think doing exercises for, 6 to 12 weeks before you see a benefit is really hard,
Mhm.
and hard to do without someone coaching you along the way. So they have to be motivated and they have to be able to contract their own pelvic floor. After that, I talked to everybody about pessaries. And, we used to fit everyone with pessaries in the office. So we use or traditional pessaries. The problem with traditional pessaries is they don't work very well, right? They have that little knob on one side. So there's a little knob that should sit right underneath your urethra. And that knob moves when you move, when your bladder fills, if you have to have a bowel movement, it moves around. And so sometimes it works well and sometimes it doesn't work well. I like the Uresta a lot. I think the Uresta is a really good option. I think because it's symmetrical and it doesn't, have this one thing that's supposed to stay there. I think the Uresta works really well. The problem that I have with the Uresta, so it's over the counter in Canada. It's not over the counter in the US yet, but they're working on that. It should soon be over the counter. The problem that I have with the Uresta is that I have to warn people about it because have you ever seen one?
Yeah.
Yeah. So, it's very firm plastic. And so
Yeah.
I always have to warn people and say, you're going to look at it, you're going to think, oh my gosh, there's no way that's going to fit in me. That's going to be super uncomfortable, right? You really have to talk people through it. Otherwise, I've had lots of women who don't want to try it. So I like the Uresta. Sometimes I will have women try the Impressa. I think the Impressa is great for proof of concept, right? Does a pessary work for you? I don't like the material that it's made out of. I think that material can be uncomfortable for a lot of people. And so you have to lubricate it. And then over time, I mean, if you leak once in a while during specific activities, I think it's a good choice. But if you're having to use it pretty routinely, it can be pretty expensive.
Absolutely.
And so that is the thing that I don't like about it. So, with stress incontinence, what happens is that the vagina is the support for the urethra, right? And over time, usually with deliveries, sometimes with pregnancy, sometimes just with life, that vagina just isn't a great support anymore. It doesn't support things quite as well. And so when you cough or sneeze, the urethra will move instead of staying stationary. And so a pessary does the same thing that surgery does. It's just pushing up on the vagina, which pushes up on the urethra, which helps things close when you cough, sneeze, laugh, jump, any of those things. So that's my feeling about pessaries. After pessaries, I talk to women about bulking agents, right? So we can inject a material into the urethra, and there are lots of different materials that are on the market. And it is kind of like filler, right? If you've ever seen pictures of people with filler in their lips and cheeks, it does the same thing in the urethra and it bulks it up and minimizes leaking. It definitely does not work as well as surgery, but because it's just an injection, there's no downtime, right? And so for some women that's a great choice. And a lot of women are very happy with the benefit that they get for the amount of kind of pain and downtime that they have, which is minimal. For me, that's also a great option if someone's having a lot of leaking, but they want more kids, right? And we're just doing something to make you more comfortable and buying time. So, and then after that, we're looking at surgery. So, yeah.
And which I want to talk about. But one thing I want to ask you really quickly, and this is something that I've experimented with using a bit, is compression garments. And there's like a little bit of data. It's not the highest quality, but I've tried it like clinically, just recommended to the odd person that isn't a surgical candidate, or maybe they're postpartum, like their body's changing a lot. And my take, and some people put on, they say, I'm not leaking anymore. And I think my take on probably what's happening is, again, a lot of times when people leak, it's like I see as a physical therapist, like a lot of tendency for a lot of tension in abdominal muscles and pelvic muscles because they're trying so hard to hold. So my take on it is that the compression garment allows them to just be a little bit more. And so there's less pressure on the system. Again, I would never say that this is going to solve all your problems, but I've actually had quite a few people put it on and say my leaking's gone down. That's interesting. But
there have been a couple compression garments on the market that are or available that are marketed just for stress incontinence. So I agree with you. I mean, I think I've definitely seen people who have benefited from it. It's hard to figure out. I don't think we have enough information right now to know who benefits from
absolutely.
it. But it's also a very easy thing to try,
Try.
right? And I think a lot of it has to do with kind of how we're transmitting pressure,
Yep.
right? And what's tight and what's loose. And yeah, I mean, all of those things become so important, right? If you are wearing a compression garment, right, is your posture different?
Mhm.
You know, could that be helping, right? There are
Mhm.
so many things
Yeah.
there.
It's
So
trial and error, I often say. And I want to talk about surgery now, but I often draw for my clients, like I'll kind of write incontinence and then I'll draw all the options around almost like spokes of a wheel and just be able to show them kind of like the things that I feel like I could help you with. Or it's a way to for us to also rule out like, hey, we've tried this, you're still
yeah,
leaking. And maybe they haven't been to someone like yourself yet. And so that's where I might be like, you've done a great job of like you're trying all this and it's trial and error. And at the end of the day, some people will pick the conservative options first because maybe that like surgery is not something they even want to entertain. And who knows, maybe they try everything and they realize their quality of life is still not what they want it to be. So then they entertain the idea of surgery. I have two examples lately of youngish women who told me that I had worked with, and they literally exhausted everything around that wheel. And one of them is like, can I please get a letter? I'm ready to talk to a urologist. And the other one was like, I had a surgery after I worked with you. I stopped coming because I wasn't better, but I just want you to know I had a surgery and it was the best decision I ever had. I'm like, great. Like that was the option that worked for you. But I do think sometimes people have in their head, should I do physio or surgery? And I was like, physio and surgery, or physio then
yeah.
surgery, or surgery with physio. Like you don't have to, it doesn't have to be exclusive.
No, and I think, you know, if someone goes on to surgery, they always do better in the long run if they've learned all of those physical therapy techniques,
Yeah.
right? They're definitely complementary. And, you know, it's almost a personality test because some people want to leap ahead to, you know, the most aggressive thing and to do
Mhm.
surgery. But you know, if you can wear a compression garment and do a little exercise and have all of these symptoms go away, that's kind of a beautiful thing,
Mhm.
right? And if
Mhm.
you know, for most women, maybe not most, let's say many, for many women, if they have tried the conservative things, and they haven't reached their goal, they feel a lot better about surgery,
Yeah.
right? The surgery feels better. I mean, the truth about sling surgery is that it is a quality of life surgery, and it is really hard for a lot of people to pull the trigger, right? And
Yeah.
say, oh, this bothers me enough that I'm going to let you cut me with a knife. I mean, who says that,
Yep, exactly.
right?
So let's say whoever it is, whether they've tried all the conservative options first, or maybe they're say, no, thank you, Dr. Boyle, I want to go straight to Boyles, sorry. I want to go straight to surgery. Will you explain, like, will you get into that now? Like, what are their options for
With
surgery?
surgery,
Yeah.
yeah. So when we talk about surgery for incontinence, we talk about sling surgeries. And a sling surgery means that I am putting a piece of material underneath the urethra, right, which is the tube that goes from the bladder to the outside. So putting a piece of material underneath the urethra to support it so that when you cough or sneeze, things close down. Um, that piece of material can be lots of different things, right? So initially, when these surgeries were done, they were made out of your own fascia that we either got from your leg or from your belly. So you had to have two incisions, one in the vagina, and then one either on your abdomen or on your leg. There have been different artificial materials that have used, different cadaveric tissues that have been used. But now the most common type of material in North America, this isn't true in all countries, but in North America is a piece of mesh. And the reason that the mesh is the most popular and considered to be the gold standard is because it works the same in everybody, right? It is um, a piece of material that is permanent that you know we tension the same way in everybody, so it's a very reliable surgery. So I can say to you, you know, it's an 85% cure, 10% of people are much better. It's minimally invasive, so it takes me about 20 minutes to do and people go home the same day. And different surgeons have different post-operative restrictions. When I first started doing these, we wouldn't let anyone exercise for about 12 weeks. But now ask you to not exercise for 2 weeks. And then after 2 weeks, you can go back to whatever you want to do. And I'll tell you that I have had runners run, 17 miles at 14 days, right? I mean, they are on the trail and running. But at that point in time with the mesh, it's scarred in place enough that it'll work, and it's unlikely that you would loosen it. When we use meshes, there are unique complications to mesh. So the unique complication that we see is that you can get an erosion, which means a little piece of that mesh can creep into the vagina. And then women come into the office and they say, my partner says there's something scratchy in my vagina. And that's almost always a piece of mesh, which is very easy to remove, to cut out. And usually that does not impact how well a sling works. When slings were first done, we thought they had to be really, really tight. And so when a sling was done, women who have slings that are, 20, 30 years old, they frequently had trouble emptying their bladder because that sling was so tight. But you'll hear people talk about one of the brand names is the tension-free vaginal tape. And we don't put them in tightly anymore, right? They kind of get activated when you cough, sneeze, jump. But you should be able to empty fairly easily with them. It shouldn't feel difficult to you, although it is always a little bit of a change after surgery.
So, and is that kind of like, how often will you not use mesh then? And why wouldn't you at this, like, for someone? What would be your reason for not?
Using mesh,
Yeah.
somebody doesn't want it.
Okay.
So I don't use mesh if someone's nervous about it.
Mhm.
So for me, I think using mesh is the gold standard. I think it works very, very well. I have very good success rates of, using it in my hands, but it makes some people nervous. And, over my career, I have found out that I don't really think that's objective, right? Some people are just nervous about it. I can talk to you about, the pluses, the minuses, the pluses, the minuses, the benefits, the cons. But if you are uncomfortable with it, then we shouldn't use it, because if you're uncomfortable with it before surgery, then after surgery, you're gonna worry about it,
Mhm.
right? And it's a quality of life treatment, right? It's to make you better. And so if it just doesn't suit you in whatever reason, then I wouldn't use it. But there's very few other reasons. I can't think of another reason why I wouldn't use mesh. Right.
And
It's also a much smaller surgery, because if I use your own tissue, I have to make a pretty big abdominal incision to get that piece of tissue out. And for those surgeries, you have to be really careful about activity.
and do you do, like, for all people, is it a vaginal surgery? Like, do you go in vaginally
So there are different types, you mean for mesh slings?
for your mesh sling? Yeah.
Yeah, so there are different types of mesh slings, and they all require a vaginal incision.
Mhm.
There's retropubic, and so you have, the place where the surgery starts and then where the sling comes out. And in a retropubic, the sling, there are little exit incisions just above your pubic bone, right? So if you put your hands on your belly and you feel your pubic bone, they would be right there. So that's a retropubic sling. Um, that type of sling is my favorite. I think that it works the best in my hands. You can also do what's called a transobturator sling. So a transobturator sling, you also have a vaginal incision, but those exit incisions, instead of being above the pubic bone, they're actually in kind of your groin crease by your thigh muscles. And the mesh comes out through your leg extensor muscles. And I don't like that. Some physicians like that surgery a lot better. I don't like that surgery as well, because I don't think it works as well in my hands. And also, a minority of women, a very small number, but some women will get kind of chronic leg pain when they're exercising from where that mesh is. And that just doesn't seem like a great trade off for me.
So would you say then, because now it sounds like, I mean, the technique is different or yeah, the procedure is different. So there's not as much the issue with it being too tight. Um, what, what other things would maybe, like you said, it's a high success rate, but what other things might people complain about after that you've seen?
So right after surgery, the way you empty your bladder changes,
Mhm.
right? And that takes a while to get used to. So it shouldn't be hard to empty, but it may take a couple of seconds longer. And you know, the way you empty your bladder is the habit. And so it is strange when that is different. Um, I've definitely had patients with erosions. Infections are pretty rare. Sometimes women will get urinary tract infections afterwards for a little bit. And that's always something that is very, very bothersome. Um, Sometimes the incisions that on your abdomen can be a little bit sensitive, and that can last for, you know, about 6 months. Um, but yeah, those are usually the big things,
Otherwise,
right?
people are pretty happy.
Yeah. hmm it's a pretty easy surgery to go through, and it works pretty well, right? So, you know, I usually tell people that, you know, if you have a bad cold and you're coughing, I think you're still going to leak a little bit. Um, but for your day-to-day exercise, you should be much better, right? It doesn't work in about 5% of people, and those people are really frustrated because they went through something and it didn't work. But you know, if you have the correct diagnosis and that person has stress incontinence, they almost always have a good deal of benefit, if not cure, after this type of surgery.
Do you usually tell them there's
But
a certain amount of time they can count on it being, effective? Like, is there a certain amount of time that you'd consider that, or no, they should
no,
last?
you know, there are other surgeries, right? Like hip replacements, you know, where we talk about, oh gosh, yeah, we're going to have to replace this over time. But the mesh is permanent. And so for a lot of people, it's the only surgery they need. Sometimes over time, you can start developing urgency incontinence. And then, you know, you're leaking for a different reason, but patients will frequently come in and say, you know, I'm leaking, it didn't work, because you're just irritated that you're leaking. You don't really care why you're leaking, right? But then sometimes we have to treat that other leaking in a different way. So no, I don't give people you know, kind of an expiration date with it.
Mhm. And so do you find that most of these people, like, again, I know you're a fan of physio, but so would you send them most often, like you said, maybe, before? More often it's, I'd like you to see someone before, not necessarily, I'm gonna, we'll do this surgery and a physio would help after. Does that make sense? Like your preference would be that someone work with someone before?
Um, so I think, and you're going to think this is a strange thing for me to say, but I think if you can avoid surgery, you should, right?
Hmm.
So if I can send you to physical therapy and you get better and you don't need surgery, then I think that's great, right?
Hmm.
And it doesn't work for everybody, but you know, it works for enough people that I think doing it ahead of time is a good idea. So my preference is to do it ahead of time. Um, and then I think it's important to recognize that maintaining a strong pelvic floor is kind of a lifelong goal, right? Because you want those small muscles to continue to work well. And so you should continue to do those exercises as you age. I think sometimes, you know, people think, oh, I'm going to do this course of physical therapy and then I'm going to be done with it, right? And that's not really how our bodies work.
Yeah, and I would say too, I mean, I agree too. I find it's actually interesting because a lot of the people that we see before, and I'll always say I'm never going to claim that physio is going to be the be all and end all for you. Let's try some things and then let's see where this takes us. And a lot of people do find they're like, okay, I don't feel like I need to go see the urologist now. I keep saying urologist because we don't have a urogyne here in my community,
Yeah.
so it would be a urologist that they're going to see. But
I mean, there are lots of people that do the work that I do,
yeah,
right? I mean, urologists do it,
yeah,
urogynecologists do it. That's totally fine.
yeah,
I think the other thing too is, I mean, you mentioned this before, it depends a lot on what that person is doing, right? People that have very high expectations of their bodies and do difficult, high impact sports are much more likely to leak, right? And then we need to do everything that we can do so that when they're doing their deadlifts, their breathing is correct, their posture is correct, their pelvic floor strength is as strong as it can be. And yes, maybe they have a sling too. But they need to be thinking about all of those other things too while they're doing those activities.
hmm. And I would say like a lot of those people that you, as a physio, that I build a rapport with before maybe they decide to have surgery, um I'll talk to them a little bit about after, and we talked to you, even mentioned too, like sometimes it's hard to pee after, it's not something we
Yep.
normally think about, but a lot of times people have, let's say, coordination issues in their pelvic floor, or a tendency for too much tension, their issues letting go. And so sometimes it's a matter of like learning how to have better control or better coordination. And quite often I'll say, let's do a virtual appointment after, because sometimes because they're not used to thinking about peeing, they need some reminders of how to let go after, or different positions that would be favorable for letting go, or
Yeah.
just exercises that would promote kind of that down training of the muscles. I talk a lot with people after. You mentioned like someone that wants to get back to running. Some people need guidance after they feel maybe a little bit more support if someone's giving them an idea of how to get back to exercise, or how to lift without pressure. Um,
Yeah. I
so
think the lifting is a big thing, right?
yeah,
And I think, for so many of us, we don't really understand how our body works, and
yeah,
especially not how the pelvis works, right? And you just kind of do what you do and what you've always done, and you don't realize, the things that you're doing that are not helping you, right? That
yeah,
you're holding your breath and bearing down when you're lifting something, right? Rather than exhaling. And, there are just so many little things that you don't think about, right? And then you see a physiotherapist
yeah,
and, they point all those things out to you, right? Yeah. Do you
yeah,
realize your one leg's longer than the other? Do you realize you're leaning to the left? I mean, there are just so many things.
yeah, absolutely. Well, I appreciate, is there anything I didn't ask you, Sarah, that you feel like's pertinent to this conversation?
I think it's important for women to know that there are lots of options out there,
Hmm.
right? I think it's important for people to know that surgeries work and are beneficial. It doesn't mean that surgery is for everybody. We do use a lot of meshes, but for people who aren't comfortable with mesh for whatever reason, there are surgeries that you can do that don't involve a mesh, and that's perfectly fine. Um, we try to avoid surgeries if you're going to have more kids, and there are other things that we can do. And I think, sometimes I see patients who are interested in having a surgery, and they go to surgery pretty quickly. But, some other times it's a, 7-year long conversation, right? Where
Hmm.
somebody, wants some information but isn't quite ready. And so we just kind of start working on things and trying other things. And, that's perfectly fine. But I think it's important for women to know that they have and there are things that they can do. Women are much more active today than they were 20 years ago, right? And that's what we want. We want everyone to be active and social. And so you should know there are options out there.
Yeah, I agree. Active, and also wanting to have a bit more role in their healthcare, because I think we're seeing a change where healthcare providers used to be a little bit more, you need to do this, you need to do this, this is next. And I think we're a little, and I think it takes the pressure off us as healthcare providers too, to almost give them a menu, because how can I possibly know what everybody needs? And I think it's not only helpful for the patient, but for us as providers to be able to give that choice, right? Education
Yeah.
and choice. And I think it works better on both ends. But I really do appreciate everything that you're doing, to help educate people. And help them understand their choices. So, and I
Yeah.
appreciate your time today too.
Yeah. Thank you so much. This has been fun.